All right, so we've got Andrew from Sydney, who's you're an exercise physiologist.
Yep,
Excited
that's
to um, dive into some of this wiki page that I wanted to create that you wanted to also be a part of. I think which can be a nice little North Star for people who are entering like the Reddit group who are lost, confused, and I think it's got a lot of good evidence-based information that can point people at least in a good starting point so that like what you said when we were talking about earlier is helping people start to understand how they can manage stuff on their own. And I think that starts with having a pretty like strong foundation of what's going on. Obviously, in conjunction with seeing like a medical provider in person or online, whatever is appropriate for that particular case. I think the biggest issue when trying to answer questions on Reddit is we don't know where people have started. We don't know where they're at, what they've tried, and having a wiki page where people can sort of go to first will start to help get people on that road, like I said. So I'm going to share. Is there while I share, is there anything that you want to add about what drew you to starting the wiki page and those things?
yeah. I think the biggest thing is just like I think education and just like understanding, getting through like all the noise of like what you've been told from like friends and family who honestly just want to help, but they end up just like kind of spreading maybe information that's a little bit outdated or information that might not be as helpful as they thought it could be. It might be super helpful in the short term and when you like first hurt your back or whatever, but maybe in the long term it's like not super helpful. It's like
Hmm.
trying to actually, I guess, show people the full picture
Yeah,
of like where to go and everything.
yeah, and there's something that I always kind of when I start to educate on back pain with people is I try to quickly help them identify that this is like a very common human experience. And so much so that like when I say human, I mean every system is involved. I think people get very focal on their diagnosis, and really there's a lot of systems at play, including like you and I talk a lot about the psychosocial factors, environmental factors, and things like that, which we can get into with the wiki page. So if we share here, let's see what the best view is. This might be the best view. If you're on your phone, you might have to squint, but um, let's look here. So the two main questions that you've kind of identified on Reddit. You want to start there?
Yeah. So I think the very first question is like people aren't really sure if they like need to see someone right now. It's like it hurts so much. It's like, should I just go to the ER? It's like, yeah, I think that's like the first question. Like, what do I do right now? It's like it hurts so much.
Yeah. So I think a lot of the time people's first instinct is I need imaging to find like the actual source, and there are some guidelines that have come out. And you were talking about how in Australia you feel like maybe as a part of like the international community for addressing back pain might be spearheading some really good solid information for like not just clinicians but people who are going to have those types of questions. So when it comes to running out to get imaging, a lot of doctors, and this could be from people's like beginning of people's frustrations, so a lot of doctors are following these guidelines where they say, well, if there are no red flags, and there are a few red flags we'll go over in a second, then imaging, the best practices say that we need to wait on imaging for somewhere between 6 and 9 weeks, depending on where you kind of read the stat there, is because there is this natural history. So the first thing is just going over red flags. So like question number one, where it says screening for sinister symptoms. So the red flags, what are some that you identify or are looking for when you're working with somebody?
Yeah. So I think if you scroll down a little bit, I think there's a little sinister symptoms list, which like you can kind of see later. I'm not sure if it's on this document, but it's definitely on the Notion page. But I think so things on the list could be like fractures. That's like a huge thing, right? It's like if you have a fracture, it's like probably do need like an X-ray or like some type of scan, because like fractures like pretty serious, and you don't want to like keep bugging it if the bones are literally like broken apart and everything. So that's like a really big one that people look for if they do have to get a scan. I think
Yeah, and
there'll be like, yep, you go first.
well, X-rays are pretty cheap, right? So when you compare MRIs, a lot of think people's frustrations are with, well, I need to know what's going on. I need an MRI, and I need it like now. Well, the red flags that you're looking for, right, are of course X-ray is a easy, fast way to eliminate if someone has a fracture. The the thing, right? So if you're not having an acute traumatic experience, there's probably less likely that you're going to have a fracture unless you're somebody that's at a higher risk for things like osteoporosis or things like that. So um, the biggest things that come to my mind when it comes to some of those red flags are um, like immediate sudden onset of weakness, like can't generate power through your lower extremities, right? That would be one where you would want like to go to the emergency room and get medical attention immediately. Um, Things that they're looking out for are also infection, um, tumors and cancers and things like that. These are among the 1% of all back pain cases, which around the world there are 660 to 700 million cases a year. So when they're looking for red flags, it's kind of on their radar that it's unlikely that there will be um, potentially these red flags, but you're always looking for them. So um, another red flag that I think would catch my attention when I'm gathering a history from somebody is if they cannot find like a single comfortable position, and having pain, especially at night throughout the entire evening. You would kind of start to you'd be tipped off maybe towards like, maybe you really do need to seek out some of this, more urgent medical attention. However, it's like if somebody can get into some comfortable positions, that seems to sort of kind of mitigate that red flag. What else, Andrew?
Yeah, I think I was going to mention something like, out of like the 1% of cases that are like pretty serious, majority of them are fractures, and it's like pretty quote unquote easy to pick up on, because like,
Hmm.
did you fall over? Are you a little bit older in age? It's like if something like that did happen, it's like, okay, probably would be a good idea to get a scan just in case you did break something, right? So it's like
Yeah,
kind of obvious in that sense.
right. There is also, these bowel and bladder changes, right? So if you've lost control of your ability to like hold in bowel or bladder, that is an immediate off to the emergency room. So when people aren't getting imaging right away and they're frustrated, I don't know if this information is coming across because we're in the Reddit group and people are like, I didn't get an MRI. They won't let me get one until I go and try PT. And so I like to just highlight this probably for these reasons. It's like if there's no immediate red flags, the guidelines have shifted towards a more conservative approach in the short term, right? We're not saying, hey, wait 6 months and then come back. It's like back pain might, even if it is ever so slightly, improve in a certain amount of time, and that's when uh, you know things are going to be progressing in the right direction because you're feeling better. But what else would you say about where we're at right now is step two, right? So if somebody comes to the Reddit group and let's say they don't have any of these symptoms like fevers or unexplained weight loss, um, dramatic balance issues, like what's the next step?
Yeah, I think probably like the biggest thing is like after you like get a little bit of clearance, quote unquote, from like not having any of these red flags, it's like you can kind of know that even though it really, really hurts right now, it's like there's a good high probability that you will get better in the long term. And I think knowing that, it's like that means we don't have to spend our money rushing to get scans and everything, and we can kind of go on a more proactive approach and like seeing other people to help you like get better without just waiting around for like medications and just waiting around for scans, because sometimes you do have to wait weeks or whatever just to like get those things to happen.
Mhm. So moving on to like step B, non-serious but still very painful. I'm not going to address the second question just yet because it's second question is usually people have gotten imaging and they're panicking. But um, first things first, like if they're not having any of these really sinister symptoms or red flag symptoms, but it still really really hurts.
I think
What
you can pull up that picture if you see the pathway of non-serious low back pain. So if you scroll up a bit, it's like a link there. Is there a picture?
Yep. So well, so is it to a PubMed article? Does it have? Let's see. Do you mean with the prevalence of like image findings, pathways of non-serious? There is an image, but it just says image. And if I let's see here.
Yeah, because I think the post didn't like it that I was trying to post multiple images throughout the whole
Oh,
thing.
that's all right. Do you want to, if you've got it, just send it to WhatsApp. I'll pull it up.
Yeah, I'll try get it there. Let's see if this works. No, that doesn't work. Wait, does
We have 3 viewers on Instagram.
nice.
We are crushing it, Andrew. Did anybody call you Drew?
Some of my friends actually do, but
Does
yeah,
anybody call you Andy?
they do as well. My
Okay.
sisters call me Andy.
Which is your least favorite to be called?
I don't mind. I've been being called both for like so long. So
My my in-laws have been calling me Drew for like 10 years. But I had never been called Drew before and actually don't prefer it. But now that's been like a decade, it's not that bad.
oh wait, I think
And
I got the link.
all right,
This
let's
should
see.
work. Oh no, that makes you download it? No way.
I can download
Okay,
it.
well, it's technically figure 1 from this link. So this kind of just shows you the pathway of like what you should expect from like the healthcare system. And I
Is
think
this
like the more we know, it's like we should kind of just understand it. Like, yeah,
you mean the more we know, just like what, just like knowing this particular pathway will help like with our decision making process,
yeah.
like in conjunction with
It's like what expectations should we have? It's like should we be sitting around waiting for scans, or should we be only taking medication, or are there actually other things that we should be going to try and seek out help for?
let's see.
If
think I
that
got it.
doesn't work, I can always screenshot it. But it's
I
a
got
big,
it.
long picture.
I
Yeah,
got
it's
it.
that one.
I'm gonna zoom in. For our one listener, I'm gonna zoom in. Don't worry. Cool. So walk us through this.
Yes, I feel like because in the medical system, and when you do see like a doctor or something, right? You only have 15 minutes, and that's like barely any time at all for them to even get a picture of what you kind of want to tell them, or what they kind of need to know. So it's like if we as like the patient, or as we as like the public know, or slash are more prepared for the actual 15-minute appointment, we can kind of just like spearhead what we need to tell them like straight away, instead of them asking us like 50 questions just to tick off some things on the list, just to make sure you are okay. And then they're like, okay, I know this person's okay now, but what do I do? I'm running out of time. And they kind of just have to guess what will be all right for you as a person needing help. And I think that's like a constraint of like the healthcare system. It's just that there's no time. So us knowing where we can go with the healthcare system can really help us be more proactive on like the recovery journey, is how I see it.
Yeah, I think this little diagram, it looks like it was made for clinicians, um, but it's really, really just having this visual here, kind of what we're talking about, those like 1% or around 1% of cases, right? Is these scary things, fracture, malignancy, or cancer, the infection, any kind of like spine, actual like spine deformity, like spondylolisthesis, and then that cauda equina syndrome, which is like the really scary, bowel
Nerve.
bladder. Yeah,
Yep.
the symptoms of cauda equina syndrome that are like really prevalent are like that bowel or bladder loss, and usually it comes from like falling directly on like your tailbone. Um, have you heard of people having also just like atraumatic cauda equina syndrome?
Not really. No.
Yeah, I think it's going to be primarily that traumatic, context or scenario. The interesting thing is for a lot of the Reddit people, they're falling into this 5 or 10% of cases, which is actually it's like I like when I get the non-specific low back pain, which a lot of people, and I made a video about this, is like they fret or stress about the fact that it's non-specific. But non-specific is actually a good thing. If you go to the doctor and they come out and they're like, they might say, well, we don't really know what your back pain is coming from, but we know it's not these two things or like these two categories of radicular syndromes, which would be that like shooting nerve pain. Radiculopathy would be that sudden, maybe not sudden, but gradual weakness of
Or
one
loss
particular.
of sensations in like just this one part of the leg or foot or
Yeah, right.
thigh.
Right, and then spinal stenosis, a normal aging process of the spine. Um, if you don't fall into either of these two categories, it's like really, really good. It's a good thing, but that
Yeah,
doesn't change.
I still think in the second group or ridiculous syndromes, you still have a good prognosis.
Oh yeah, absolutely. Yeah. I
So
just think people where I was going with that is like, and thanks for bringing that up because I think people go, oh, well, I'm, not 90% of the cases. But what happens is I think people say non-specific and they're like, well, I want a specific diagnosis. And if you're not getting it's like non-specific back pain just really says, well, it's just not falling into two of these, categories.
yeah,
So, and that's 90% of the cases that come into the you know, primary doctor. So,
yeah. So I think in my head, it's like non-specific is like kind of saying it's not um sinister. So
mhm,
it's not something that they need to get on and get on top of right now to fix, quote unquote.
mhm,
It's like this is something that we can deal with ourselves and rehab through it instead of
yeah,
like waiting for something to happen to us. It's like let's try and be proactive in this journey since it is non-specific and not super scary. It's just super painful.
yeah. And I think what sucks is like it doesn't change the fact that it like really hurts, even though it's non-specific and it's great. It's like okay, well, I fall into the 90%. Um, what's nice about the 90% is it's primarily self-limiting. So what you're kind of pointing out to is like there is um, some effort or control that is in our power. And I think when you have a debilitating back pain case, even if it is non-specific, you are limiting. And it sounds like, oh well, it's like you're just limiting yourself, but it's really just that when you become aware that you can tolerate a little bit of discomfort with the guidance of a professional, then you can actually move on with it and go in a direction. So that limiting is your belief is I shouldn't move or I shouldn't I shouldn't do exercise. I have to protect my spine. Those are those some like self-limiting factors. So really good image. Since we're coming up on 25 minutes or so. What else do you want to continue to go through this, or you want to continue to kind of highlight the wiki and the purpose of that?
I think we can just finish off this little table because I feel like it just kind of ties it up there.
Sure, sure. So you'll notice that in the graph, it just if you have right the orange category, there's no treatment recommendations on this graph because those are
You need more
emergencies.
specialists to like
Yeah,
look into it and really get to the bottom of that.
right. So if we move on here, treatment recommendations, like both of these, like you said, Andrew, are good prognoses, low risk of serious disease, immediate imaging not necessary. And I think a lot of people, which ties into the other question on the wiki, which we probably won't get to today, but is people, they just come in and they just like paste their MRI report, and they're kind of in sheer panic. And I think someone the other day was even like, after getting some feedback from somebody who self-identified as not a medical professional, which we don't allow really medical advice on the like to be given so freely about certain things like MRI and surgery, on the Reddit group, kind of scared, created a lot of anxiety around their report, but it ended up actually being like a pretty normal uh, image of the spine, which we can get to on like another day. So knowing that it's a good prognosis is being active and reassuring, and education that, hey, maybe we need to just, what it says right here, pacing, which is like, how do we conserve our energy throughout the day so that we aren't like running into the ground a little bit with our current uh, pain response.
Yeah, we're not like continuously aggravating the area. It's like how do we find not pain, it might not be pain free, but like a position or ways to move around that's not as aggravating to however which way sensitive for you, I guess.
Yeah. Um, so throwing this into radicular symptoms, acute non-specific low back pain or persistent low back pain, right? So we got anything that's radicular, anything less than 6 weeks is considered acute. Anything over 6 weeks is starting to go into that persistent category. Um, I like that under radicular symptoms, it says pharmacological is opioids are like rescue only. I think so many people are afraid of using medications. I know in the US, I don't know what it was like in Australia, but in the US, we're still trying to come back on a lot of the opioid overuse and the opioid crisis. But the fact that it says like rescue only, it's almost like, hey, there are going to be times where you need intervention from the pharmacological side. I don't think you need to be afraid of that. And obviously that's coming from the side or like the intervention with your medical team, um, like your GP or even a neurologist.
Yeah, I feel like it's such an interesting topic because like sometimes, oh, I guess the current expectations are when you do go to like a GP or whatever, majority of the time people expect to be like given something like a medication or whatever, compared to like a referral or just quote unquote education or reassurance.
Hmm.
Like what does that even mean? And I think in GP appointment it's like impossible for them to like even explain that since it's such a big topic and it's so individual to each person. It's like what movements piss off your back when you move. It's like, is
Hmm.
it bending? Is it staying straight up? Is it like bending backwards? Everyone's so different. It's like it's so hard to explain.
And I think that's where finding that like movement professional, that can really identify, okay, like, hey, here's the starting point in terms of movement. And that's where we try to skirt around that limiting, that self-limiting, where we can say, here's a starting point, here's an acceptable level of discomfort, and then let's guide you through this as you kind of navigate some of that natural history of that normal amount of time it takes to overcome some of these things. Um, what's difficult, like you're saying, is it's like there's not a lot of time when you're with your GP, and sometimes these people, they can't not go back to work. So you're really you have a population of people that can't just take time off from work, and so that like that pharmacological approach can be helpful. But um, I find resonating with people on that level where it's like, all right, like how am I going to take care of myself when I have to continue to go back to work? So finding movements quickly can be really helpful.
Yeah. So I think that whole movement exploration thing is like super important for people to figure out with somebody who has experience in that space. It's like, yeah. And that will be different for like every person. It's like
Yeah,
maybe the typical straight back using your knees more might be the perfect response for somebody. And then maybe for someone else doing the exact same thing, it's like, no, bending my back a little bit, having a stoop posture feels better when I just move around.
Um, yeah, and that's not enough time to get into why like the McGill approach like does wonders for some people and doesn't for others, but that's like under the same umbrella where it's like individually
Everyone's so
everyone's
different.
gonna respond differently. Yeah. Um, okay, so let's just highlight the main differences between if you have an acute back pain episode that is or something that's more persistent. What is the biggest difference here?
Hmm.
I mean, the first three categories are very similar. Um, the interventions that are more conservative is like you start to see management of certain other factors like sleep, mental health, and stress and things like that. Whereas in acute, while I think education and reassurance can kind of stave off some of that acute anxiety, uh, what you find in the chronic pain population is there are many, many lifestyle factors that are going to be more probably profound. So I like, I think having that distinction is important.
Yeah, I think for the acute, non-specific low back pain, it's more so like, how do we calm the nervous system down?
Hmm.
And pretty much that simply just means like, how do we reassure you to know that, or to get you to understand that, hey, even though it really hurts right now, you have a good um chance of like good recovery in like the upcoming weeks,
Hmm.
and like everything will get better. And I think it's just like understanding that and staying active and still moving around, and like also learning how to move around without pissing it off too much is like really important in the early stage.
Hmm. I think I'm just gonna finish off discussing that real quick because should we be should our screen should be on top of each other or you want to be right? Oh, that's better. Okay.
Yeah, that's good.
Still learning. So I think where people get into trouble with some of these ridiculous symptoms, I think this will help a lot of the Reddit group, is the idea of like running yourself into the ground is you go from potentially being like able to do independently pretty much anything that you want, right? To all of a sudden this acute nerve root or disc injury and or even ridiculous symptoms. Um, there's a reason I said injury versus just symptoms because sometimes you might not have like a full on disc herniation or like extreme injury, and you can still have radicular like symptoms, but that's another time. Um, is essentially like you have to scale back a lot. Like doing a lot less. I think people take a break and then all of a sudden they're feeling slightly better and then they re-aggravate. So a lot of the strategy for dealing with radicular symptoms is w- how do we work around it versus I find with a lot of non-specific low back pain it's how do we lean into a little bit of the discomfort because it's not as debilitating. So with radicular symptoms when you essentially spark that really acute symptom like keep re-aggravating it, that's where it's really hard to overcome it because you're not recognizing that, oh well, I used to be able to just pop out of bed and walk around and do all my chores. The nervous system can't tolerate like a full day's worth of like bandwidth now. So, what are your thoughts? Is there anything you want to add to maybe the two different approaches to radicular symptoms and non-specific low back pain?
No, I think you covered that pretty well there. It's just like, how do we, I'm pretty much going to repeat what you said, but it's like
That's
pretty
fine.
much how do we work around this thing that is aggravating, right? It's like, are we going to find out ways to move so it doesn't aggravate it as much? And that's like the whole exploration and pacing thing again.
Yeah,
So
not easy for sure. I think just kind of end off of that. Like both you and I are clearly like really passionate about helping people with chronic back pain. I'm think you have started like an awesome wiki. I think once we get it actually into um, the wiki page on the Reddit group, you can find it on the links tab inside the Reddit group. So, other than that, is there anything else you want to add? Other than we might be doing this on a weekly basis for the Reddit group.
Um, I don't think so right now, but I think if anybody has any suggestions or any topics that they want us to cover, it's like feel free to like either DM us or leave a comment, um, either in like the little thread and everything that
Mhm.
Andy put up.
Yeah, and if you're a clinician that wants to get involved, we are looking for like more evidence-based clinicians to kind of help because it's like really an uphill battle. I'm realizing more and more I get into trying to educate on this. Is there's just you know I think so many people have found different ways to overcome back pain that when you ask, and Andrew kind of brought this up in the beginning, is like when you ask your family member, they've got one thing that worked for them and the next thing doesn't work, for the next person. And so you'll see people specifically call out chiropractors. I think it's more about the interventions and narratives that the practitioner will use. So it's not so much chiropractors as much it is maybe not so much the evidence-based approaches like the one that the manipulation that will help stave off viral conditions like COVID. But that just silly things like that. These are narratives people buy into, and it can actually be more harmful. So we're looking for clinicians who might be passionate about back pain, who want to contribute and just help more people on the Reddit group because it's chaos. I don't know how else to describe it. I think um, it's we're trying to sort of give people a North Star.
Yeah, I think right now it's like there's so much good evidence for like us clinicians, but now it's like how do we translate that to just like everyone else, right? No,
Mm.
not everybody's a clinician, so it's like how do we bridge this gap? I think
Yeah.
that's what the little pathway and journey that we're trying to bridge right now or build right now.
All right, Andrew. Good night.
All right,
It's your
thanks,
bedtime.
Andy. Yeah.
All right, dude. Cool. I'll talk to you guys later. And thanks for watching the replay. If you find us on Reddit, have questions, feel free to hit us up.